Hello and welcome to your second lesson on postural and phasic muscles. So in this particular lesson we are going to cover things that relate to posture, and many of my patients have said to me in the past, you can see it here, things like, do you think I have good posture? Or I know my posture is really poor, or is that why I'm in so much pain because of my posture? So you probably find it yourself, many of your own patients and athletes that you will see naturally might relate their lower back pain, thoracic pain, neck and shoulder, to maybe sitting at a PC all day, every day. Thomas in 97 discussed posture as the attitude or position of the body. Martin discussed 3 of these functions that you can have a read in your own time. So during this lesson I will talk about some relationships of posture and how we can influence neck and shoulder pain in particular. So let's move on to this page. Now, naturally your eyes will be drawn to this picture. But before we look at that, have a look at some of the text. It does talk about good posture and poor posture, etc. I do think in the world we live in today, especially the use of the mobile phone, we spend most of the time basically looking down. And as a result of that, if you think about your own screen time on your, let's say, iPhone, then, most people, I was teaching a course recently, and I think one of the students says on average he has about 5 to 7 hours per day just on his iPhone. I thought I was bad, around 1 to 2 hours. So just bear that in mind. If you're always on your phone or your iPad or your computer, naturally you are going to be looking down, and as a result, over time, it's not going to happen overnight. But if you're looking at this text here, it says in the rounded shouldered patient. Okay, so for instance, many people do feel that they have this sort of posture where they slump, and things like that. But as a consequence, you might find over time the thoracic spine develops into what we call a kyphosis. So the curvature, if you're looking at this side here, you can see the curve is increasing. I can actually use my pen over on this side. There we go. That's fine. So I can actually, if you're looking at this sort of shape, you can see there is a development of a kyphotic curve. And as a result of that kyphotic curve, it changes the position of your scapula. Okay, so basically it will rotate forward and downward. And then as a result, it then changes the position of your acromion and the glenoid fossa, which is naturally relates to the shoulder complex. The downside about the change of posture and the result of a relationship to the shoulder, etc., it can increase the chance for many conditions, impingement syndrome like the bursitis, impingement of the supraspinatus. It can also relate to what we call TOS, which is called thoracic outlet syndrome, which are many causes, and position, if you like, a position and posture are naturally related to that. Cervical spine facet joint, just to name a few. Now, when I teach the shoulder course in particular, or the cervical course, I will get my students to almost slump like this, okay? So basically just slump and then just try to flex the shoulders, and they will notice that the movement will be very limited and it's uncomfortable. So you can try it yourself, basically just let yourself slump a few degrees and then try to bring the arms overhead and then sit up straight and then see the difference. So what that means is the thoracic spine, even though the shoulder will go to in total to here, okay, almost like 180 degrees, the last 10 to 15 degrees of that flexed motion will be coming from the thoracic spine. So if a thoracic spine is developed into a kyphosis, and that can be minimal, then it's going to limit how much the shoulder is basically going to flex. Okay, so just bear that in mind. Now the treatment for that we will discuss as we go through it, because it's only lesson 2. We've actually got 22 separate modules that comprise this course, so it's pretty intense. So we will go through things like the arm elevation test, looking at the length of the pectoral muscles, because if the pectoral muscles are particularly tight, then what they do, so the pec muscles at the front. In this lesson I will talk to you about the Yanda, a guy called Vladimir Yanda, and in 1988 he talked about the upper cross syndrome. So for instance, if the pectoral muscles along here are tight, then what they do, they'll cause an inhibition to the posterior muscles known as the rhomboids. So a muscle at the front becomes tight, causing potentially a lengthening, weakness, inhibition to the antagonistic muscles. So we'll discuss that as we go through. So let's move forward along here. So if you're looking at a couple of these pictures, this one in particular, so you can see Eric Dalton, he has an article which I like, and he calls it the 42-pound head. So it's a good article. So ericdalton.com. He's basically like a rolfer based in the States, US. So if you're looking at here, so for instance, the weight of a head, give or take, is around 10 to 12 pounds, give or take. So for instance, if it translates forward, just translates here, okay, so it goes forward 1 inch, then basically it adds on 10 pounds, so it now weighs 20 pounds, okay, so 20 pounds. And again, if it translates again, another inch, it's now 30 pounds, another inch is now 40 pounds. So it doesn't mean the weight of a head is 40 pounds, it's almost like a leverage. You know, if like a crane is picking up a heavy weight, then it might have a heavy weight posterior to it, like a ballast to counterbalance that. So for instance, if a head has gone forward a few inches like this, then the load is naturally going to form around here, almost like to what we call the cervical dorsal junction, which is between the cervical spine and the dorsal spine, which is the thoracic spine. Okay, so you can actually call that the cervical thoracic junction as well. And you might notice with people, they might form a dowager's hump just here, which is basically a formation of the adipose tissue as a result of a head going forward. And I think even Dalton talks about the more the head goes forward, think about the structures. Okay, so this area here is almost like a thoracic outlet. The definition of a thoracic outlet will be compression of the neurovascular bundle, and then the neuro is the brachial plexus, which comes from C5, C6, C7, C8 and T1, and also you've got the subclavian artery, and then they will pass between the anterior and middle scalene muscles, and then they will go over the first rib and under the clavicle and under the pectoralis minor. So if we have any form of compression here, and it could well be because of a forward head posture, then you are going to get symptoms that relate to potentially a thoracic outlet. And also respiratory function, because everything is forming around here, it becomes tight, and almost uncomfortable. So you might find the breathing mechanics will be altered as well. There is a pain cycle here, that you can sort of get into, and it's difficult to get out of this in some ways. Because if this has been developing over, say, 5, 10, 20, 30 years, then patients will come to us and they almost expect us to fix them, like in one 45-minute session, which is a bit unrealistic. Okay, so it's quite complex how we would help these people. It's not just we massage the back muscles and it's all fine, because it doesn't work like that. Okay, so we will have a look as we go through. Now, the guy mentioned, Yanda, Vladimir Yanda, he died sadly in 2002. So he had a concept about what he known as the tonic or postural muscles, and the muscles what are known as phasic. Now you can see here, there's some pictures further on, but what we've got predominantly postural muscles and predominantly phasic muscles. So when I look at the tables shortly, then on this left-hand side, along this side here, okay, you can see these particular muscles, like the pectoralis major, minor, levator, trapezius, they relate to the position, like the postural muscles, and they have a tendency to shorten and become tight. And the phasic muscles, which are predominantly related to movements, tend to become lengthened and weakened. Okay, so like the rhomboids, the lower traps, mid traps, etc. So they tend, but it's typically as a consequence. So you could argue that the postural muscles control the phasic muscles. So if the pecs are tight, it basically causes an inhibition weakness to the rhomboids. But let's have a look at that as we go through. There is some pictures here, like a table. So it follows like a trait. So a postural muscle relates to posture, okay? A phasic muscle relates to movement. You can see that they're different types. But the important thing is that as a reaction to position, i.e. posture, over time, then the postural muscles have a tendency to shorten, whilst the phasic muscles have a tendency to lengthen. So these become short and tight, and these become long and weak. And you can have a read of all the details of it in here. The purple muscles on this side will relate to the postural muscles, and then the green will relate to the phasic. Moving on. This was quite a nice picture. These are taken from my books I've written. And this is the whole body, yeah, along here. So the purple muscles, like the adductors in this case, the rectus femoris, yeah, the adductor muscles in here, the TFL. Yeah, and you can see all these pectoral muscles, the sternocleidomastoid, etc. They are the postural muscles. And then the obliques, yeah, the tibialis anterior, etc., the gluteus, yeah, the rhomboids, lower traps. Then these are what we call the phasic muscles. So if you think about sit-in as an example, if you sit in, then the psoas, there's a psoas there. Okay, so the psoas comes down, you know, with iliac somewhere in here, can't really see that well, but in the iliac fossa comes down. So that's naturally going to be in a shortened position. And so are the hamstrings, well, part of it. Then you'll find that they will be the antagonistic muscles to the glutei. So you might find if you test the glutes and they are inhibited, then you might find it's not about let's strengthen the glutes and everything's okay. It might well be that it's the psoas muscle that is controlling the glutei. So just bear that in mind. We'll talk about a study shortly. Yeah. So another study by Yanda in '83, you'll see the table in a second. And he basically looked at muscles of the rectus abdominis and then the antagonist muscles of the lumbar spine erector. When I get to that picture, it's probably easier for me to discuss that. And one of the mnemonics I use will be a tight muscle will basically pull the joint into a dysfunctional position, and the weak muscle will allow this to happen. Okay, it's a modified sort of adaptation that I've used from, I think it's from Muscles and Testing by Kendall, which is a good book. And I have a mnemonic where I talk about lengthen the short before you strengthen the weak. So for instance, if you're looking at, say, the psoas and the gluteal relationship, you would lengthen the psoas before you activate the glutes. If you've got weakness in the rhomboids, you would lengthen, say, the pectoral muscles, the major and the minor here, before you would activate the rhomboids. Let me explain that in the table over here. So this is a study, quite an old study, but I explain this to my students on a regular basis. So for instance, what Yanda did, like I used to look after the rowing team of Oxford, so many of them will have what we call a tight lower back. And sometimes what people do, as in therapists, they'll say, well, the muscles of the lower back are really strong, so you might need to counteract it by doing some sit-ups. That's not really going to work, because if you're looking at this here, okay, so what Yanda did was, so he's got like an EMG, and he placed it onto the rectus abdominis, and he asked the patient, if you like, to do a sit-up. And you can see there is a contraction of the rectus abdominis here. But what should happen is that the opposite muscle, the erectus spinae, okay, so erectus spinae should switch off. So for instance, if you pick up a cup of coffee, the bicep is contracting, but the triceps should relax. Now, if you've got a tight lower back muscles, then what Yanda found was the erector also contracts as well as the rectus abdominis. Yes, it's a bit less, but it's still contracted. So then it means that you're not really going to get a strengthening in here because it doesn't contract fully. It's almost like delayed. Now, what Yanda did was says, well, let's lengthen the short muscle before we strengthen the weak muscle. So he said, okay, let's look at lengthening. And in this, not this lesson in particular, but lesson later on, when we're looking at the erectus spinae, I will show you like an MET and some soft tissue techniques that you can do for those muscles. And then after lengthening, he then retested. And look here, okay, so you can see now that the rectus abdominis has more contractibility than what it did. Nothing's changed apart from stretching the erectus spinae muscle. But the most important thing is that, look here, okay, there is no contraction of the erector after lengthening those muscles. Okay, so you're still doing a sit-up, so nothing's changed. Okay, sit-up motion here, sit-up. It's like a little curl up, not all the way up. So this muscle contracts more, and then the erector actually switches off. And then if you were to test the, I don't particularly like this exercise. This is like a dorsal raise. Why? Because most patients or athletes tend to lift too far. They hyperextend. So I'd never really recommend this exercise here. And the facet joints in the lumbar spine tend to become irritated, because you're almost forcing them to close, and they're all little synovial joints. So you can see this is the EMG recordings of the muscle activity before lengthening the erector and after lengthening the erector. And that's why that mnemonic, if I go back a page, along here, so we will lengthen the short before you strengthen the weak. It's like the glutei. So if you're doing, so if you've been told you've got, say, a weak glute medius, you might find if you lay on your side and you lift your leg, like a class, they have what they call their legs, bums and tums. But if you lay on your side and lift your leg up, if the glute medius is weak for some reason, then it's not really going to get any stronger. Why? Because you might find that the adductors, which are strong and tight, are almost causing the weakness inhibition to the glute medius. And if glute medius is weak, the TFL muscle, the tensor fasciae lata, will get stronger, and perhaps the piriformis, because that's going to be a weak abductor, extensor, lateral rotator. So those muscles actually get stronger. So by doing that side leg lift, like hip abduction, then you find that the glutes actually gets weaker rather than stronger. Even the quadratus lumborum will assist. So maybe before you try to strengthen the glutes abductors, as in glute medius, then try to lengthen the adductors, and you might find that will work very well. Even like here, so before you try to strengthen the glutes, you lengthen the psoas. Before you try to strengthen the rhomboids, you lengthen the pecs, and so on. I hope that makes sense. And again, you're into this sort of like faulty loading, what we're saying, if you're sitting in front of a PC all day, every day, then the muscles become shortened. As a result, the antagonistic muscles, which are known as the phasic, will lengthen, okay, and then it alters the movement patterns, it overloads the musculoskeletal, because of a change of a position, and actually pain injury. And the downside is that the patient comes in and says, oh, my neck hurts, and then a lot of people will treat the neck and not really look at the causative factor. They only tend to look at the symptoms, okay. Now, Yanda, in 1998, discussed what they call the upper cross syndrome, okay, the UCS here. Also got a lower cross syndrome as well. I want to show you the picture for that because it makes a lot of sense. And this is actually the last couple of pages along here. So I quite like this. I know it's old school. I think Yanda said that's what he was famous for, where he discussed the upper and lower cross syndrome, but he did a bit more than that. Very influential in the sort of physical therapy field. But look here, okay, so look at the cross. So we got the cross shape coming here, excuse my drawing, across there. And what he discussed was if you've got tight, say, pectoral muscles, then you might find if you're going it this way, okay, yeah, then obviously you'll have weak inhibited rhomboids and serratus, etc. But as part of this cross, you've got these tight upper traps and levator along here. And then as a result, you've got the inhibited neck, the deep neck flexors become weakened. And then you've got inhibited rhomboids, trapezius, mid traps, lower traps, and serratus anterior. There's a serratus here. You can see it's in blue. Okay, these muscles are in blue, which are inhibited. These muscles are in blue. The rhomboids around here are in blue. And then you can't really see the upper traps, but these muscles here, the green muscles, where they are. So you can see the traps and levator sort of drifting around this sort of area. Become shortened and tight. So remember the head now, it goes forward. Even the sternocleidomastoid, which is a postural muscle, will become short and tight as a result of that position. And then the formation here, the suboccipital muscles become short and tight, and then that can cause lots of symptoms, headaches. The neck muscles become short and tight, like a levator and things like that. So that's an interesting concept. I always say to people that to control the cervical spine, you control the shoulder position. So if you only work on the cervical spine, you're not really going to reduce many of the symptoms. However, if you try to control the position here, okay, the whole position here, and look at this, then you might find the position of your shoulder dictates the position of your neck. And if your shoulder is rounded and you're kyphotic, then naturally you might have this forward head posture, this translation of the cervical spine. And as a result, it gives you all those sort of symptoms. So just bear that in mind. But also think about it from a lower perspective as well. So you can ask yourself a question is, look at the pelvis, look at the lumbar spine. If you're hyperlordotic, you might have something called a lower cross syndrome. I don't have a picture in here to show, but that's basically where the lower cross in the would relate to the psoas muscle, and the erector spinae muscle would become, so this would be, say, the psoas and the erector here in this line with the rectus femoris, and then on this line would be the glutei and the rectus abdominis, the abdominal muscles. Okay, so that would be the lower cross. Okay, that's the lesson complete. I hope you've enjoyed it. Ready for the next lesson, and thank you for watching.